Hi, my name is Dr. Carina Kugelmas, and I'm a pediatric nutrition specialist at Denver Health Medical Center in Denver, Colorado. And today we're going to be talking about some of the hidden causes of cholestatic disease in children and a deep dive into progressive familial intrahepatic cholestasis and other pediatric cholestatic diseases. And this is my co-host, Dr. Rima Fawaz, that we're fortunate to have here today with us.
Hello, I'm Rima Fawaz. Thank you, Carina, for the introduction. I'm a pediatric hepatologist, and I'm the medical director of pediatric hepatology and liver transplantation at Yale School of Medicine, New Haven.
So just to start today, Dr. Fawaz, I thought we might talk about if we had a 1-month-old term baby with prolonged jaundice and some poor growth. What are some of the initial tests that you would order to evaluate this child for the prolonged jaundice?
I mean, obviously, we just said that this talk is going to dive into the cholestatic liver diseases, but just to start us off, I think any baby within the first 2 months of life presenting with cholestasis, we have to do kind of an expedited workup to rule out biliary atresia, which is not an inherited disorder, because that's a time-sensitive diagnosis, and that usually obviously starts with fractionating the bilirubin and doing the next steps to rule out biliary atresia, which might include an intraoperative cholangiogram and or a liver biopsy.
So once you've ruled out biliary atresia, what would be kind of your next steps to look into other causes of cholestatic disease?
So usually cholestasis is, when I'm doing teaching to my fellows, I'm saying cholestasis is always abnormal. It's kind of the equivalent of having bleeding in your GI tract. Like if you have bleeding is never normal and it needs further investigation. Cholestasis is the equivalent of that. There's no physiological state where you would have true cholestasis, meaning a total, a high total bilirubin and direct bilirubin. So usually in our mind, at least in hepatologist's mind, we usually think of, is it high GGT or low GGT? This is something we always are thinking about, and almost most of our cholestasis are usually high GGT. So biliary atresia, Alagille, alpha-1 antitrypsin, and the less common are the low GGT. And usually when I have a low GGT, I'm always thinking of cholestatic genetic disorders. And usually that would involve more genetic testing.
So at your institution, if you did genetic testing, when might you get those results back?
So usually, I think every institution is a little bit different, and people should utilize what their institution has at hand. Usually, if somebody has low GGT, something I can do that I have a very quick turnaround time is bile acids. Because when you do total bile acids at my institution at Yale, it results within 24 hours. So I have a direction whether this is, I'm dealing with low, bile acid synthesis defects where you have low GGT because you're not producing any bile and hence you don't have injury to the biliary epithelium. And if it's high bile acids with low GGT, I'm thinking more along the lines of progressive familial intrahepatic cholestasis. Obviously, these are the two big categories, but there are other genetic syndrome that have low GGT with high bile acids that don't fit into this category. So serum bile acids, and usually we have access to the prevention genetic kits that we, as of now, this can change, but we can send out free, so at no cost to the patient. And the thing that's important is that sometimes, depending where you practice, it can be prohibitively expensive for patients if you send like a whole exome without checking into their insurance and other steps. So usually I do send the prevention genetic testing for these children.
So is that the cholestatic kind of genetic panel
Yes.
that you send? Okay. So I guess in the meantime, until you get, I assume that there's time delay in terms of getting those results back. What other type of testing do you need to do in terms of to evaluate or make, decisions on treatment for this patient or next steps for this patient?
And I'm sorry, I didn't answer your question about the time, the round time. So with the prevention genetics or the genetic cholestatic panels, typically around take 3 to 4 weeks. You don't have the luxury to, call and say, can you expedite it? It is what it is. If sometimes on an occasion we'll have an inpatient that we're very, very worried about having something, we'll involve our genetics team. And in the inpatient setting, you can have a quicker turnaround if you do an expedited gene panel. But as we wait, you really can only do supportive therapy, meaning making sure the baby is, and for a nutrition expert, you know very well, on getting formula that is more medium chain triglycerides. That the medium chain triglycerides, as you know, they don't need the bile salts for absorption. They're smaller molecule. They're absorbed in the upper part of the intestine. So we don't need that micellar formation to absorb them. So we make sure the formula is appropriate. They're getting extra calories to compensate for the fat malabsorption that is happening because of the cholestasis. And, typically you would want to check fat-soluble vitamins and supplement with fat-soluble vitamins appropriately.
So can you talk us through a little bit the different types of, assuming this patient, we've figured out that they have PFIC. Can you talk us through a little bit about the different types and what other types of manifestations they might have in the different types?
Sure. Also, I want to mention that in the past, we used to do liver biopsies on these patients, and now we really drag our feet in 2025 because the genetic testing have helped us so much. And many of these liver biopsies can look just so non-specific. So we really are not doing a liver biopsy until we have all the genetic testing come back. So things have reversed. But PFIC, these are rare diseases. The incidence of all PFICs are probably 1 in 50,000 to 100,000. So definitely a rare disease as compared, I want to give you the incidence of biliary atresia in the United States, which is around 1 in 12,000. So very different. And Alagille syndrome is like 1 in 30,000. So we're talking a much rarer disease. But out of all the PFICs, PFIC2, which is the bile salt export pump deficiency, is the most common, which is a low GGT cholestatic liver disease. It usually manifests early on in life. So in that first year of life, you typically will have manifestations. And they can have very severe pruritus. And many of these patients, we transplant them because of the pruritus. And with PFIC2, out of all the progressive familial intrahepatic cholestatic syndrome as a whole, they have a higher risk of hepatocellular carcinoma. So we're watching them like a hawk. PFIC1 is our traditional Biler's disease, the Biler's bile that we used to see on electron microscopy. That is a more multi-system disease involvement and has manifestations in the liver, has GI manifestations, which are usually diarrhea, failure to thrive. They can have hearing deficit, some intellectual disability, much more different organ involvement. And PFIC1, much rarer, but remains a very big challenge because also these patients don't respond to the therapies we have of today. PFIC3 is another commonly seen genetic disorder and definitely under-recognized. There's more now education about thinking about it. It's the high GGT. Out of all the progressive familial intrahepatic cholestasis syndrome, it's the only one with the high GGT. It's the transporter is the MDR3. It transports phospholipids from the hepatocyte into the canaliculus. And you can imagine if there's no phospholipids in that bile mix, you can have more bile duct injury, lining of the bile ducts. Then you can have more injury and then higher GGT. And the difference with PFIC3 is it can present later on in life. So sometimes we see it in adolescence and even now in the adult world, in patients with small duct PSC or AMA negative PBC, or really undiagnosed liver disease with some different manifestations. Half of the patients with PFIC3 can respond to ursodiol as a treatment. The other commonly seen, symptoms that we need to think about this diagnosis is sometimes with drug-induced liver injury and in patients that get cholestatics when they're on birth control pills. And those maybe don't have the full, 2 copies to manifest autosomal recessive disease. I'm sorry, I might not have mentioned that before, but all the progressive familial intrahepatic cholestasis are autosomal recessive diseases. That means you need 2 copies to manifest disease. Nowadays, we now know if you actually have heterozygosity, you might still have some manifestations of disease in states where they lower your production of that transporter. An example is pregnancy. If you are heterozygous and you have, instead of 100% production of the transporter protein, you have 50% production, during pregnancy, that might be down-regulated. Now you're at 30%. So these pregnant women get very itchy, and obviously the treatment is delivery of the baby, and then they're totally fine. So that's something you have to think of heterozygosity for PFIC3.
Thank you. It's fascinating how much we know now, of genetic diseases. So I know that pruritus or itching is one of the most, difficult parts of this disease, and especially for children. What are some of the treatment options for the pruritus that we have available?
So, we've come a long way, and we're still, I think most hepatologists will use ursodiol. I think we stopped talking about ursodiol because it's already kind of the, platform where we start with. So most of all our patients are on ursodiol because, as you know, it's a water-soluble bile salt. So kind of you want to replace that pool of bile salts with a more soluble and we think choleratic bile. Once that fails, most people would consider rifampin is a second-line pruritic, for pruritus management. And beyond rifampin, I think it's really, we use different things, but when you get to that point, you're also not in a good spot because, some people use naltrexone, like antihistamines to help with the sleep at night, but typically, they don't respond. And many of these patients go to transplant because of that indication. If in the world of progressive familial intrahepatic cholestasis, we actually have data that can tell us now, we didn't have it before, what if we look at the phenotype, we can predict the expression, if we look at the genotype, we can predict the phenotype of the patient. And sometimes if you have no expression of the protein, like the transporter protein, like, for example, truncating mutation with BSAP, those patients will go to transplant because, one, they don't respond to anything. You have 0 bile acids going into your gut, so really no therapy is going to help. All the bile acids, salts are staying in the hepatocyte, causing damage. And those patients have a very high risk of hepatocellular carcinoma. Before we had all this correlation, we used to do surgical intervention, what we call the partial biliary diversions or ileal exclusion, basically they were trying to take out the part of the ileum that, is responsible for intrahepatic circulation of bile salts, hoping that you will waste the bile and over time you'll decrease your bile acid pool. From their surgical interventions, actually we have very solid data that we use in clinical medicine that tells us if you actually respond to that intervention and you decrease your bile salts to less than 1 or 2 micrograms per deciliter, I think, don't quote me on the unit, or less than 75% of your bile salts, actually that's very good prognosis. And those patients do well without liver transplant. And those parameters now we use in clinical medicine, where when we have these patients, I think most of us will go to ursodiol, some will go to rifampin, and then we'll go to the IBAT inhibitors, the ileal bile acid uptake inhibitors.
So that was coming to my next question. How have the IBAT inhibitors like Maralixibat and Odevixibat changed the landscape for PFIC? Is that something that's, you still don't use those first line? Is it more of a third-tier option, or are we getting towards using them more first line?
Thank you. That's a very good question. I think most of us will all use ursodiol because it's so cheap, so easy to get. The IBAT, I think most hepatologists, and I think there is more awareness among gastroenterologists that those definitely should be used when there is pruritus. They're pretty effective, but not 100% effective. And they basically prevent, it's basically it's the surgical equivalent. It's the equivalent of surgical exclusion surgeries. It's just a medical counterpart that is reversible. So these medication basically bind to the, ileal transporter for bile acids and kind of blocks it. And since we shed the intestinal mucosa every few days, then you have to keep taking the medication to keep that block. But you're wasting the bile acids, and over time you decrease your bile acid pool. They're FDA approved for kids. So I don't think if any child has pruritus, we will definitely use it. Sometimes it's hard to approve through insurance. I think we've gotten much better now that we have FDA approval. And they have changed the landscape because these patients used to get transplanted for pruritus. That was one of the major indications for transplant. And now we have a medical option that removes the transplant from the table. So yeah, that's huge.
Are there also other benefits? I mean, improvement in growth, or whether direct or indirect from, using the IBAT inhibitors? Or?
So I think more data is coming. Stay tuned. These medications were FDA approved for pruritus. That was the primary goal. So it's very hard to say that they're going to improve liver health. Like conceptually, you think, of course they will, right? They're decreasing the bile acid pool. Bile acids that stay in the liver and are very high, they're going to attract inflammation. That's how we have bile salt, injury to the liver. So you would think they'd improve liver health. But the data so far, we don't have that, data for these patients. We do have data where they published from the GALA, which is the Global Allergy Alliance study, that they looked at patients that received Maralixibat and compared them to case match controls that are historic. And those patients fare better, and there is a higher 6-year survival with the native liver. So they are preventing us from doing liver transplants. Part of the reason is we used to do the liver transplant because of the pruritus, right? So you're removing the indication that they were getting transplanted for. Now, in those patients, they do describe that patients are growing better, more to come on that. And some of the theories is maybe they sleep better and you secrete growth hormone during your sleep. So maybe you're doing better because you're actually sleeping better. I don't know whether you also eat better, because they're not helping with the digestion or absorption, right? So they have nothing to do with that. You're just getting rid of that pruritus.
Right.
So more to come. But yes, very exciting time for pediatric hepatology.
Yeah, that sounds great. Any other, future directions for treatment options like gene therapy or precision medicine? Anything in the pipeline?
I mean, I might not know, but I don't think we're that close. We have gene therapy for other pediatric indications, such as like OTC, ornithine, the urea cycle defects. We're still not in any point in time where, one, it's a totally risk-free intervention. Because you have to have enough gene expression to prevent you from having symptoms, right? I don't think for the common cholestatic disorders we have anything in the pipeline for gene therapy. To the best of my knowledge, I might be off. I think we're good with the IBAT for now. Yes.
So if we have some general pediatricians out there listening or watching this in the future, what would be your one pearl as far as to not miss, these cholestatic diseases? Because I think that they do get missed often.
I think my take-home message is anybody with jaundice at any one point in their life, they should have fractionation of the bilirubin, because that tells us if it's cholestatic or it's something like benign, like Gilbert's, which we typically manifest more during adolescence, although it's a genetically inherited disorder. And once you have cholestasis, please know that this is not normal. You have to send to a gastroenterologist or a hepatologist, depending where you practice. And now we have approved therapy to make these kids feel better. Another pearl for the pediatrician is that sometimes if we don't ask about itch, these parents and patients have lived with itch all their life. They don't even report as having itch. You can see indirect like excoriations on the skin, or, they have dry skin, but you have to really ask for it and ask how they sleep and ask the parents because we have now a treatment for that. So it's exciting. Yes.
Well, thank you so much for joining us today. And that was very informative. And thank you so much.
Thank you very much for having me.